want to turn to what I was just referring to, and that is, how do you keep this thing going? Because, as we've talked about before, during the implementation period and during the time when there's a lot of attention focused on getting the checklist into place and modifying it, and it tends to be at the front of our attention. But as soon as we turn our eyes away to the next problem that we need to start working on in the operating room, be it redosing of antibiotics or changing the skin prep to the latest and the greatest, or whatever it is that we're going to work on next, a lot of times the thing we just worked on, in this case the checklist, starts to slide a bit. So I want to talk about a few things that can affect the slide in a positive way. Now, one of the first things, and Dr. Morowitz talked about it, and so did Julie, having those one-on-one conversations. Again, they're in a smaller hospital where that's maybe a little easier, but it's possible even in larger facilities if you divide up the work to actually do it. Those one-on-one conversations can prevent a lot of the issues that lead to early problems when you take your eye off the ball. So again, I can't emphasize enough, I don't know where you are exactly in your implementations, but if you haven't done one-on-one conversations or you haven't finished them, I would encourage you to keep talking to people, keep asking for their help, keep that message going across that this is about our patients and it's not just about us. I want to talk about how to fix problems as you encounter them in your operating room, and Julie touched on actually what we think is probably the best way to bring it into your operating rooms in the first place, and that is to have somebody there who understands the checklist from the implementation team actually coach it in the very beginning. And even though Julie didn't use those words, that's exactly what she did. So she would be there, she showed them how to do it, and then she was there as they actually did it to coach them through it for the first time. That can help tremendously. It's also a way to bring things back if stuff has started to slide in a direction that you're not happy with. If you identify a team or team member that's not using the checklist, that's a time to either talk to the team or to talk to individuals to kind of push things back to where you want them to be, to where the checklist is being used effectively. So what are some of the things that you could start to do right now as you actually go to implement? So I just want to remind you of some things, and actually Julie and Dr. Morowitz brought a number of these points up. Use the observation tools to see how teams are actually using the checklist and coach them, and then don't stop. So make a plan to go back and look in a month, and go back and look in a month after that, and keep looking, because it's that keep looking that can keep performance of something like the checklist at a high level until it becomes just the way that we do the work here at our hospital. Collect and post instances when the checklist catches something, and that's what Dr. Morowitz has built into his daily practice. We need to all think about that and reinforce the importance of doing things like this to each and every one of the members of the operating room team. Consider having individual conversations with frontline staff, including physicians, and ask them how they think it's going. Even after you're done, go back and see what they think about it as they use it more and more. Now, we've gotten some very interesting feedback from physicians who were initially reluctant to use the checklist. After they use it for a while, if they go to a hospital where it's not used, they actually are uncomfortable because they come to trust it as a way to keep their patients safe, and they don't feel as safe when it's not being done. That's where we all want to be eventually. We want people to feel like things aren't safe when they don't use the checklist. And then one of the things that we'd like you to do as we continue to do this work is to repeat the culture survey with us in about a year. So when we have those phone calls in the future, the check-in calls, that's one of the things that we're going to remind you about, because one of the things we want to know up here in Boston, because I think it would be incredibly helpful to other people, does the way that people feel about safety in your operating room change over time in a positive way because you use a safety tool like this? We're convinced that it does, but we want to make the evidence that actually proves that it moves things in the right direction. I think it would make it easier to convince other people to follow the path that you guys have already